Hi, everyone. I'm Nancy Siebold, the COO and Program Manager of PALTOWN, a nonprofit whose mission is to empower cancer patients through community and education. This video conversation provides a look at Guardant Reveal, the first blood-only liquid biopsy test for residual disease and recurrence monitoring for early-stage colorectal cancer patients. It's part of a new module in PALTOWN's online education program for colorectal cancer, COLONTOWN University. At PALTOWN, we have two main programs for CRC patients and caregivers. COLONTOWN is our private Facebook community serving over 6,000 colorectal cancer patients and caregivers in 120 groups focused on every aspect of the CRC experience. COLONTOWN University is a public space offering multimedia learning centers. These resource libraries are organized around some of the hot topics in COLONTOWN, like clinical trials and diagnostic and surveillance testing. Guardant Reveal is featured in the Testing Learning Center. In addition to videos from clinicians about the latest research and patient-designed tools for understanding your biomarkers, the Learning Center has sections for specific tests developed in collaboration with the test companies. Reveal is our newest module to be launched in the fall of 2021. So to talk about Guardant Reveal, we have Dr. Manju George, PALTOWN's Scientific Director, and Leslie Bucheit, Medical Science Liaison within the Medical Affairs Division at Guardant Health. Manju is a researcher in cancer biology as well as a rectal cancer survivor. She combines these experiences in her work translating the latest research for the thousands of patients and caregivers in our COLONTOWN community. And Leslie is a certified genetic counselor with clinical experience in cancer genetics, who now works as a medical science liaison at Guardant Health to educate others on their tests and data, as well as conduct research.
Thank you, Nancy, for that introduction. Welcome, everyone. Let's get started. Let's make sure that we're on the same page. So starting with, what is a liquid biopsy and what specifically is MRD?
Yeah, that's a great question. So liquid biopsy gets a lot of attention these days because of the excitement around these tests. So let's think a bit about what the test is actually measuring, and then we can understand how it works in an MRD setting versus not. So everybody has short fragments of DNA floating in their blood. And while most of that DNA comes from our normal cells, in patients who have cancer, we can see small fragments from their tumor circulating in the blood. And we often call this circulating tumor DNA or ctDNA. And so a liquid biopsy test can look at a couple of things, but in this case, it will look at a blood sample and will look for these ctDNA fragments that can often give us insights into someone's cancer. The vision of liquid biopsy and why everybody's so excited about it is that it can actually, we think, be used to help screen patients for cancer. So right now, where patients get a colonoscopy or a mammogram, what if that was just a simple blood test to be able to find early fragments or patterns in someone's blood that suggest they may have cancer? Right now, liquid biopsies are often most frequently used in advanced cancer settings, so metastatic cancer settings, and they're used to look at the specific genes within someone's cancer and say, okay, how can this be used to help plan treatment or see how well treatment's working or determine if cancer has come back even. So MRD is a version of a liquid biopsy. MRD stands for minimal residual disease. And what this test does is it often assesses to see if there's a small amount or very microscopic amount of cancer that remains in the body after we otherwise thought someone was cured of their cancer. Maybe this is after surgery or after surgery and chemo or chemo and surgery, whatever order those things may fall in, right? We don't have great tools right now to sort who's likely to recur and who's not. And we know particularly in patients with early stage colorectal cancer that we think are cured after, standard of care right now, surgery or chemo. We know that some will go on to recur. And right now, we don't really have a great tool to identify accurately who will and who won't. And so a liquid biopsy MRD test is something that is just a blood test for the most part that with Guardant Reveal that can be helped used to answer that important question and try to sort these patients into who's likely to recur and who's not.
Okay, thank you. So when we hear Guardant Health, people automatically think about Guardant 360. So how is this new test, this MRD test, different from Guardant 360?
I think that's a good question. I think when we think about the continuum of cancer and someone's journey across the stages of cancer, we can get a little more insight into how these tests are similar and how they're different. So here at Guardant Health, we've got Guardant 360. Again, it's often going to be used in that advanced cancer setting, really looking for therapy matching or tracking how someone's cancer may be evolving while they're on treatment. We also look mostly at DNA mutations with that test. For Guardant Reveal, we're moving upstage earlier in the cancer journey, and we're really trying again to sort who's likely to recur and who's not. So it's more of a yes/no answer compared to Guardant 360, which gives you a lot of information on the genes within a cancer. And it looks at two signals, DNA mutations, and it looks at methylation patterns within someone's blood sample to try to do that sorting.
Thank you. Is Guardant Reveal the only test that uses blood, or do you need tissue? Can you explain a little bit more?
Yeah, so Guardant Reveal is the first test that is blood only to look for minimal residual disease. So we don't require tissue. What's important to know about liquid biopsies as a whole is that ctDNA we're looking for is a very small amount in someone's blood. And so for lack of a better example, let's think about a needle in a haystack, right? So the more the advanced the cancer is, often the more active that cancer is, meaning it might be dividing fast, it might be shedding really fast into someone's blood. And so we have a bit better chance of identifying that ctDNA in an advanced cancer than in an early stage cancer where Guardant Reveal is used. And so what we've done with Guardant Reveal is, when we move upstream, sometimes that haystack is about the same size, but the needle is much, much, much smaller that we're looking for. A way to mitigate that in some regards is to use tissue, right? And to kind of control for some of these background noises within early stage cancer samples. But another way to do that is looking at multiple signals within someone's blood sample. And that's what Guardant Reveal does. So Guardant Reveal, like I said, it looks at DNA mutations that we know are associated with early colorectal cancer development. And then it looks at specific methylation patterns unique to colorectal cancer. Methylation is something I say it's like a light switch on your genes. So it often is used to silence genes. And so cancer genes are often, they'll create tumors and our body says, don't do that. And so if the genes are turned off that says, don't do that, then we see tumors starting to happen. And that's really that methylation piece. And so what we can do is look across someone's ctDNA and say, okay, does this have a methylation pattern that's consistent with early stage cancer that may be more likely that then this patient would recur. So with Guardant Reveal to be blood only, we look at two signals to keep the test as accurate as we can and to help really be able to identify more patients who may have remaining residual disease.
Okay, so I think I heard you say that the methylation markers are specific for colorectal cancer. Is that right?
Yeah, that's right. So, what enables Guardant Reveal to be blood only through this methylation process can sometimes be our rate limiting step, right? So what Guardant's doing, and we've put some early data out in other tumor types, we essentially have to validate our test in each tumor type to be able to train our bioinformatics and train our callers essentially to find the proper methylation patterns across someone's sample for colorectal cancer versus lung cancer versus something else. So right now, that's also why Guardant Reveal really is only available for early stage colorectal cancer as well.
Okay, so I can imagine a couple of advantages of just having to use blood for the test. Could you tell us more about it?
Yeah. I think back to the days when I was a clinical genetic counselor. So I used to see patients in clinic, and it was one of the best things about my career and something that really drives my work every day. And I was really passionate about Lynch syndrome, which is a lot of folks associated with COLONTOWN University will know is involved with hereditary colorectal cancer syndrome. And back in the day, which was not too long ago, to screen someone for Lynch syndrome, we would have to do MSI testing on their tumor by IHC. And so, when I think back to that day, I think about, okay, the guidelines say we're going to do IHC testing. So I'm going to work with our pathology to get your tumor block, and then we'll do this. And hopefully we'll be able to look at all the genes, but maybe not. And this isn't even when treatment was pending. Like this was more for risk, or, the patient had been treated. We didn't have immunotherapy at the time. And so I just think back to that time when my patients were pretty frustrated with the time that took. And my providers were also pretty frustrated with the time it took because they really just wanted to know what is next for this patient, what's next for this patient's family. And in that time, we knew we had blood-based genetic testing through a multitude of laboratories that could look at someone's, genes and give us a pretty quick answer. Back then, it was still like a month. It wasn't as quick as it is now, but it was certainly faster than waiting for that tissue plaque and doing that IHC. And so I think with a blood-based approach with Guardant Reveal, it's a very similar paradigm. Historically, we've been looking at tissue, or maybe we're looking at tissue now. With a blood-only test, we don't need to go through the hoops it often takes to get that tissue. And tissue can be a really precious resource for other things that we need to look at. And so I think this just enables easier ordering and certainly faster time to results for patients, which is really important in some of these settings where big decisions are being made based on, a patient's likelihood to recur, which can be clarified with Guardant Reveal.
Okay. When might a provider use Guardant Reveal? At what time in the patient's journey?
Yeah, so right now we think there are two places in a colorectal cancer journey where someone could consider using Guardant Reveal. The first we often call post-surgery, and this is more for patients who are often stage 2 and have the opportunity to be cured by surgery alone. And we know across MRD studies, not just our own, but several, that if a patient has ctDNA detected after surgery, that they are highly likely to recur. And so Guardant Reveal will be offered in that setting. So kind of, for about 4 weeks after surgery is the earliest we do it, to identify ctDNA and clarify if that patient is likely to recur. And often we do about 2 to 3 tests in that setting to be able to clarify over time. The second setting we often think about is once everything is done. So surgery is done, or surgery and chemotherapy is done. Right now, people are actively surveilled with CEA and scans and things like that. And so we actually think Guardant Reveal can be used then to monitor the patient over time and catch that early recurrence as soon as we can. There's sample reports of both of these scenarios in COLONTOWN University Learning Center. And an important distinction here is that Guardant Reveal is not used on active therapy. So we're not used to track changes during therapy. This is really a yes/no result to determine if a patient's likely to recur and drive that provider to action based on that result. And the other thing I'll say too is this can be a one-time test. So we have kind of these programs for post-surgery where it's multiple samples and surveillance where it's going to mirror essentially what you do with CEA now. But let's say maybe a patient or a provider isn't quite ready for those. We do have one-time tests. So maybe a patient has a CEA that's high and a scan that shows nothing. That may be a scenario where a patient or a provider wants to have a test like Guardant Reveal to clarify, because we do know with ctDNA, there's greater accuracy and earlier time points compared to things like CEA and scans.
Okay, thank you. I think I saw like a paper that came out recently with Reveal on Twitter. Do you want to tell me more about it?
Sure. So the paper we did was with Massachusetts General Hospital, and what the study looked at was really to predict the recurrence of patients with colon or rectal cancer. And so, this study really gets to my last point that we're kind of learning over time of how ctDNA can be more accurate and also kind of anticipate a bit when recurrence may happen. And so in this study, it was published in Clinical Cancer Research, we saw that 1 in 4 patients had ctDNA detected at the end of treatment, whether that was surgery or surgery and chemotherapy. So this means 25% of patients who had completed treatment and we thought were otherwise, quote unquote, cured, had remaining evidence of cancer. And in all of those patients, we saw that those who had a year of follow-up, all of the patients with ctDNA detected went on to recur. So we call this positive predictive value. That just means, when we see something, is something else likely to happen? And so we did see that here, unfortunately, for patients who had ctDNA detected, that again, they all went on to recur. So the authors of this paper compared Guardant Reveal to other things as well, right? They compared it to something like CEA, which is clinical practice now, and really what we use to inform a lot of these decisions alongside some other features. And so excuse me, they were able to assess the performance of both tests between Guardant Reveal and CEA. And essentially what we saw is that, CEA predicted a bit of who would recur and who didn't, but Guardant Reveal was far more accurate. Guardant Reveal also was able to identify patients much earlier than scans. And so put all this together, like, what does this mean, right? From this study, the authors were able to demonstrate that Guardant Reveal achieved really good performance without the need for tumor tissue. And so I think when we think about how does Guardant Reveal fit into the care plan now for someone, this study was able to show it's easy to do without tissue. It's a bit more accurate than CEA, and it can give us a bit of a peek before a scan would identify something.
Okay, thank you for that. So could you take us through a patient's journey, and like say a patient that is diagnosed now, and where all they could add the Guardant Reveal and how they would use it?
Yeah, absolutely. So with Guardant Reveal, let's just say, okay, your doctor says, we're going to do Guardant Reveal. What happens next? So the logistics of it is it's just a simple blood draw that can be done either in someone's office, or we do have mobile blood draw services. And of course, I think a lot of folks experienced those during the height of the global pandemic. But what happens then is the blood gets sent to our lab, and within about 7 to 10 days, a result is returned to your provider, who would call you and discuss it with you. And then you'd get access to that result afterwards. And so it's an important question to think about what these results could mean for a patient, right? So this is a binary test result, meaning it's going to give a yes or a no. ctDNA was detected, positive. ctDNA was not detected, negative. That's a little different than some other tests that are available to patients now. So if it's positive, what we saw in our study that we just talked about, right, is that that's a high likelihood for recurrence. That doesn't necessarily mean we're going to give you chemotherapy, or you're going to get more chemotherapy, or we're going to do this. It could just mean, we're going to monitor you a bit more closely. We're going to move up your next scan. So the call to action can be actually pretty broad with that positive result. And we've got a number of clinical trials ongoing to help us understand how these positive results can truly be used in the treatment of patients. Does giving more chemotherapy in people who already get it, is that meaningful if they're ctDNA positive? Or does giving chemotherapy at all in patients who are ctDNA positive after surgery, is that meaningful? And so we've got a number of trials to look at that, but a positive result, what I want folks to hear is that there could be a kind of a breadth of things that could occur then, not just active treatment. In a negative result, in our study and others, we did see that patients who are ctDNA not detected or negative, some of them actually went on to recur. And, this isn't unique. If we think about CEA now, that absolutely happens. And so what we know with patients who are negative is that it doesn't mean you won't recur if you get that result, right? It just means that we're going to keep following you the way we always follow you. And I would argue that including Guardant Reveal in that is helpful. Again, remember the needle in the haystack. We're looking for a very small needle, and we are very, any liquid biopsy is at the mercy of how that cancer is going to shed that ctDNA into our blood. And sometimes it's just not very active, especially in early stage cancers, right? So if it's negative, we can, enjoy that it's not positive, but we should not have the false hope of like, it's, for sure going to tell you you're not recurring.
Okay. Yeah. So what I hear is that if you get multiple negative results, maybe that gives you more confidence that nothing is growing in your body. But the positive results, sometimes, that might mean that you can't do anything about it. I mean, you're a clinical genetics counselor, you used to be, right? So I'm kind of wondering whether, in general, a cancer diagnosis is associated with increased anxiety, right? What tips do you have for people who might, consider this test and, who are not really sure what the results might be?
Yeah, I think that's a really important question for us to talk about and for any patient to talk about with their provider who's considering honestly any liquid biopsy test. Like maybe I'm biased because I'm a genetic counselor and used to talk to people about what would you do with this information? How do you feel about this information? What support do you have for this information? So I think what it truly boils down to here is that this is a risk-based test, right? We're getting a peek into what could come next. And so, sitting across from patients for years, I would encourage them to think about scenarios that maybe they had experienced that in the past. If you knew what was coming and maybe that wasn't great, how did you handle it? Is that information you'd want to know? Would it change something you do now, right? And so I really would just encourage patients to get really reflective on that, and then really dive into some key questions with your providers. What I do know from working in oncology is oncologists and patients have a very special relationship that's often really collaborative and is a rich ground for these conversations. And so I would encourage patients to talk to their providers and ask, what's my recurrence risk now? Again, this ctDNA is just a piece of this puzzle. We know that we have other tools now. We just think ctDNA is giving it a bit of a crisper vision. And so, thinking through what's my recurrence risk now? Is it already high or is it not, right? Thinking through what the test can and can't tell you. And then on your own as a patient, how would you feel if your cancer could come back? I think that's something that patients think through often throughout their cancer journey, right? This isn't unique here. And so just being mindful and reflecting on how you manage those high anxiety situations in the past and kind of those risk scenarios in the past, I think will be helpful. And recognizing that there are support groups. There are patients who are having this test. So leveraging, folks at COLONTOWN or local cancer centers might be really helpful. But ultimately what I say to folks, and even my own family who's like, you do really cool work, is like, I do. And cancer is cancer. There's not one test that will give us the roadmap of what to do next. And certainly that applies to Guardant Reveal, where, we're still learning a lot about how this can actually be used in treatment and what it actually means for patients.
Okay, and so shifting gears a little bit, I often hear in COLONTOWN that, there are a lot of, all the ctDNA related stuff is around colon cancer, and that rectal cancer patients feel a little abandoned. So I'm kind of curious to know if, Guardant Reveal and how it applies to like colon versus rectal cancer patients.
Yeah, I hear that often too from providers. They're just as frustrated, I can tell you that. And so what I think is important to note is, so to start, rectal patients were included in that study we talked about. So we've got a peek of information into that journey point. But what's really important to think about is Guardant Reveal is right now is intended to be used after surgery. And so if we just think about the treatment paradigm of rectal cancer, where patients get chemo or radiation before surgery, there's a couple questions that come to mind, like, how do I know which patients should get surgery and shouldn't, right? But also, how should I know if patients need more chemotherapy or less chemotherapy, right? It's the same type of sorting questions as in colon cancer, but it comes before surgery. And so, I think the excitement around Guardant Reveal and MRD tests in general, but certainly Guardant Reveal, which doesn't require tissue before this, kind of surgical event, is that it could potentially be used to sort patients and to help address who needs surgery, who doesn't, who needs more chemo, who doesn't. And so it's a really interesting question, and we are generating a lot of data on this. Others are generating data on this. And I just don't think we're quite there to answer those critical questions yet, but we certainly are watching and certainly are active in this space to provide answers to patients and their providers.
So how is Guardant making the test accessible to patients? So, when patients ask about the test, what are some key pieces of information that we can provide them?
Yeah, so there's great resources in the COLONTOWN Learning Center on this as well, COLONTOWN University Learning Center on this. But at a pretty high level, Guardant provides support throughout the process. So when we think of access, we think, okay, does my provider know about it? Does my insurance cover it? What does this mean for me? So we've got a slew of folks educating providers on this, from just one-on-one interactions, like that's what I do quite often, to conferences, to sharing data, right? And research and being active in clinical trials. So we are kind of, hitting the ground running and making sure folks understand and appreciate this blood-only approach to MRD assessment. From the kind of access point, truly with insurance, Guardant really walks anyone through for any of our tests, insurance eligibility, and the billing process. And so what'll be important is if you proceed with Guardant Reveal, just make sure to sign the back of a test requisition form that actually enrolls a patient in our Guardant Access program at no cost. And what this does is it allows us to verify insurance and call you if there's any out-of-pocket over $100. Our founders are very passionate that we don't want costs to get in the way of a test that could literally change the course of someone's cancer trajectory. So Guardant will work alongside anyone to try to help clear any hurdles that may block them from getting a test.
Yeah, thank you. This has been very informative, and I think for people in COLONTOWN University as well as COLONTOWN, the Diagnostic and Surveillance Testing Center will now have a piece on Guardant Reveal. We already have lots of information on Guardant 360, so this will add to the resources that we have available. And I also want to say this, that yesterday we had a talk from Dr. Stacy Cohen about the use of ctDNA for colon and rectal cancer. So it might be good for people to go listen to that talk and look at these resources, and then, that'll help us. She also talked a little bit about trials, so this would be kind of really useful to patients, and we look forward to more studies and more results that tell us how to use these tests. Thank you so much.
Yeah. I just had one thing, I think Guardant is really well known in the oncology space. And so when patients, if you go to providers, make sure you ask for Guardant Reveal, because if you just say the Guardant test, it's likely it'll be Guardant 360. And so Guardant, we're really excited. We are, extensively published in the liquid biopsy space for that advanced setting. And we're really excited to continue that data development in early stage cancer to answer all the questions that certainly patients and providers will have, and to start bringing answers to early stage colon and rectal cancer patients. So we're so excited to partner with you all, and certainly serve as a resource for you and your patients in the future.
Okay, thank you very much.
Yeah.